Good morning to all of you, and we'll start the session and the first talk of the meeting. Limbal stem cell deficiency. This is a patient that 17-year-old female who presented to us in LVP when she was 10-year-old. So first she underwent a limbal allograft, cultivated limbal allograft in one eye, and it worked well for some time. After a few years, she could not afford immunosuppression, so therefore the graft failed. And then in the left eye, she underwent a COMET, cultivated limbal oral mucosal epithelial transplant, followed by PK, and that also went bad after after 6 months. And this she becomes like this in both eyes. So in 2009, we did a Boston type 1 K-Pro, and with that she is able to see in the left eye 20/20 and 6, and she continued to have a good vision for next several years that I was following her. So when we say about limbal stem cell deficiency, we need to understand that the ocular surface is a complex structure which is maintained by the preocular tear film with its components, surface epithelium, and the ocular surface sensitivity. And the various parts of the ocular surface consist of, the mucosal epithelium exposed to the environment. The elements of the stable preocular tail film are compositional factors, hydrodynamic factors, and both of them are important to maintain the surface. And this balance is coordinated by two reflex arc at the brainstem level. The limbal stem cell deficiency or the limbal stem cell, the location and all that is now not a question. There's a lot of basic science research which talks about it and well documented. This is the transition zone between the cornea and sclera where the palisades of Vogt housing the limbal stem cells, and there is a niche, or you can call the limbal stem cell houses or apartments, where these cells are maintained and they grow out from there. These are the basically etiology of acquired limbal stem cell deficiency, congenital, immunological. This is a study that we had done in LVP between 2005 and 2014, and this is the till date largest study of limbal stem cell deficiency etiology, where you could see in 1,300 patients with 1871 eyes, the 60% of them, or the majority of 66 means 70% of them are male, and mostly both eyes are equally affected, and unilateral versus bilateral is 60 to 40, unilateral being more. If you look at the median age, it affects young adults in their 20s and 30s. But at the same time, you look at less than 15, pediatric age is also a substantial number. The visual acuity, most of these patients had a very bad visual acuity of 2200 or less. The extent of limbal stem cell deficiency, there was a majority of these patients had total stem cell deficiency. If you put 7 to 11 clock hours and total, that becomes about 70–80% of these patients. And these are the distribution of each cause. Ocular surface burns is by far the commonest cause. Then comes the VKC and AKC. Mostly VKC, I would say. AKC is very less. SJS or 10, the aniridia, mucous membrane pemphigoid, and unknown causes. If you look at the unilateral causes, 85% of the patients are due to surface burns. And bilateral causes are very different. They are mostly immunological mediated diseases. Ocular surface burns are one-third is VKC, and about 20–25% is SJS and 10. Within the chemical burns, the identifiable causes are, lime burn being the most common. So if you look at the limbal stem cell deficiency, it leads to significant visual impairment. Majority of them are chemical burn, and most of them are due to alkali burn. Unilateral versus bilateral, that determines the prognosis. Therefore, the causes are very different. And this is another classification which is published, is the based on the clinical presentation. You have stage 1, stage 2, stage 3. depending on the central cornea 5 millimeter affected or not affected. So in summary of this section, these stem cell deficiency can be dysfunction or destruction, and that will determine the treatment. For diagnosis, essentially diagnosis of LSCD is clinical, and these are the clinical features. And more here you can see there is a conjunctival ingrowth onto the cornea, because the limbus, loss of limbus causes the loss of barrier function, and conjunctiva grows onto the cornea, and this epithelium is unstable, so it may break down, causing recurrent epithelial defect and redness. These are the patients with VKC, with stem cell deficiency. Investigations, again, mostly diagnosis we make by slit lamp biomicroscopy and with fluorescence staining. Impression cytology is very rarely used unless you are if you are doing a research. For example, fluorescence staining can tell you much more about the surface and its health, especially the epithelium. The AIOS2025 intersegment AIOS2025 can give you little better insight about the depth of pannus, areas of corneal thinning, perforation. In vivo confocal microscopy can give you little more details, especially the cellular structure and subcellular basal nerve plexus. Management, mild cases, generally if it is peripheral and focal, then generally you need only topical drops or maybe scleral lenses. Moderate cases may need AMT, or severe cases would need stem cell, some sort of stem cell transplant, especially maybe SLAT, and severe bilateral may need keratoprosthesis. So this is another algorithmic approach, which is again published in one of our papers. This is more dramatic presentation. For limbal stem cell surgery, the cornea should be wet. There should not be any anesthetic component, and it should not, for an autologous transplantation, wet eye is preferred. So in SJS and OCP, generally the outcome of these treatments are not very good. So definitive management of stem cell deficiency is stem cell transplantation. It could be in the form of direct conjunctival transplantation, limbal conjunctival transplantation, or a CLAT, cultivated limbal epithelial transplant, or simple limbal epithelial transplantation. For bilateral, there are a variety of options, and we will talk about it briefly towards the end. And this is the rationale of doing the transplantation, because the limbus is lost, so you replace the limbus either directly in direct limbal grafting, or a cultivated, or a SLAT. And this is how the surgery was started by Safer Singh and Kenneth Kenyon way back in 1988-89. Biopsies they started taking from the corneal side. If you see the technique we developed, we start the dissection from the scleral side or conjunctival side and come towards the limbus, because this gives you an advantage of plane of dissection. With this, you know exactly which plane you are in. If you start from the corneal side, you don't know what plane you are. And this is a technique that we developed in LVP long back of cultivating the stem cells, and we did a very large number of patients, more than 1,000 patients, and the largest study was reported from there. And this technique now is come to know as, or reported as, LVP technique of culturing the stem cells. And these are the papers published extensively in this area. And this was the largest study in IJO. Then we started realizing, the cultivation depends on the lab, the cost is much more, and the patient have to wait for 2 weeks. So this technique of doing simple limbal epithelial transplantation came into being in 2009-2010, and the first paper appeared in BJO 2012. And the technique, as its name signifies, is quite simple. I'll skip the surgical video and look at the outcomes. If you look at the outcomes, this is like within 6 weeks, before and after. This is 3 years. And this is more than 10-year follow-up of the same patient. And this is another patient with 12-year follow-up. And these are confocal microscopy before and after. These are subbasal nerve plexus. And there's a unique thing we observed when we are doing this SLAT. If you wait enough, the cornea continues to clear. And this is the case in this patient, that vision improved to 20/40 in 5 years' time. So we conclude that currently the SLET is the best technique, whatever the way you evaluate, and you don't need a lab, and the cost is significantly down, and it's a basically democratization of the stem cell transplantation. For bilateral limbal stem cell deficiency, there are different options, like K-Pro is one of them, and this is done extensively starting in 2009. This is a brief video clip I'll skip, and these are the post-op management. So we have, two type of Boston type 1 K-Pro from Boston, Oro K-Pro from Orolab, and Lucia, another version from Boston type 1. We have been doing this technique since 2009, both. So Oro K-Pro we have done 54, and at that time, and this paper is published in AJO. So we wanted to compare whether the outcomes of performance of Oro K-Pro, our indigenous Indian-made K-Pro versus Boston-made, are any different. And to our satisfaction, we found that both K-Pros performed very well in different situations, and there was no significant difference in adverse events or retention rates. Briefly about cultivated mucosal epithelial transplantation, COMET. We take the biopsy of the lip, grow it like limbus, and these are some of the patients. We did about 19 patients, and after that I had stopped doing these surgeries because I did not find any significant improvement in the vision. And so for me now, if you look at bilateral LSCD, primarily it is the Boston type 1 K-Pro or a AIOS2025. This is old data, therefore I am just sharing. And these are some of the AIOS2025 patients. This is their graft survival of 3 different techniques. This paper is published in Ocular Surface. When you look at the results of these eyes, bilateral eyes, there were conjunctival limbal allograft in 11 eyes, COMET 19 eyes, AIOS2025 28 eyes, and K-Pro 31 eyes of 30 patients. The visual outcomes of AIOS2025 and CLAI are comparable, and the results of all 3 modalities are better than those of the COMET. Sight-threatening complications are significantly more likely with K-Pro because if the things go wrong, the deterioration can be very, very rapid. Therefore, you have to be very, very selective, very careful. This is an example of a patient in which we did first AIOS2025, and then after 10 years, when her vision started deteriorating, that I did a K-Pro. So this can also be a good option in bilateral limbal stem cell deficiency, that you do not do both eyes at the same time. You keep one eye as a reserve, as a stepney, and operate maybe 10, 12, 15 years later when you need. That way you can improve the useful vision for longer number of years. So COMET visual results to me are not very satisfactory. K-Pro, good visual outcomes, and immediate outcome can be achieved. AIOS2025 or AIOS2025, now I do exclusively AIOS2025, and that are giving very good results. So in summary, for unilateral and bilateral limbal stem cell deficiency in wet eyes, SLET is the best option. For bilateral, you'll need systemic immunomodulation. K-Pro and allo limbal transplantation is a good option for bilateral patients, especially chemical burns. For immediate visual recovery, I would consider doing a K-Pro in bilateral LSC, especially if some young patient or a pediatric age group, I may do a K-Pro first rather than doing a limbal allograft. In these patients, you need to be having a lot of patience and considerate for patients' perspective. And you should keep always long-term perspective in mind because these complications do develop, and you should be efficient in managing those complications. Thank you very much.